Thanks for joining us here on this Friday. We're here with Yappy. I'm Jared Johnson, and I'm a board-certified pediatric dentist. And today we're going to be covering pulpotomies, and we'll talk a little bit also to indirect pulp therapy because I know that's very popular. I still do it in my office. It's a great service for a lot of our patients, but there still are times where the pulpotomy is going to be a necessary procedure to be able to save a primary molar. Moving in here, I do have to disclose that there is an honorarium provided today by Septidont for the webinar. This all came about from the AAPD guidelines. It's a great resource for you in your practice. It's free for you to look up on the AAPD website. And they do systematic reviews to create these, and they really do a good job. They came out in 2017. There was a revision in 2020, and then the last study to revise the guidelines was last January that came out, a systematic review. And a lot's changed in this last decade with pulpotomies and vital pulp therapy. We'll cover the old guidelines, and then we'll cover what's changed and what's new. Some things might surprise you a little bit, which is exciting. It's exciting to see that our profession move forward. Again, you have these available online access. I know one just came out about airway, and just exciting to see that our organization is one of the leaders in the world of providing dental care and guidelines for practitioners to have the best outcomes for our kids. Again, these are going to be the things that we're going to cover in the AAPD guidelines. We're going to cover indirect pulp therapy, or an indirect pulp cap or liner, you might call it, direct pulp cap, the pulpotomy, the main one, maybe why you're here today. The other options we aren't going to cover: no treatment. That's always an option, is to do nothing. Not always the best option in some of these deeper lesions. And then extraction is another viable option, especially if behavior is not going well and you know you're not going to be able to perform a pulpotomy on a kid that's a little out of control in your chair if things don't go the way you planned and you already started and you're halfway through things and you know you're not going to be able to finish it. A lot of times at my office we'll plan for the pulpotomy and the extraction. If you know need be, then we don't have to stop and we can change our plan with the parent right there. You're going to see this logo, American Academy of Pediatric Dentists. That's going to be coming straight from the guidelines. These are the materials that they did cover in the first one. Now you're going to see a shift to calcium silicates as the gold standard. So I want to cover these because I still think there is value. Not everyone here is probably going to be using a calcium silicate. They cost more. They have different materials with handling, and some of those things may be difficult for some practitioners to go by, especially if you're in an area where your reimbursements are low and you're not going to be able to justify that cost to do the procedure with the calcium silicate. So I still want to cover these. I think some of these are great to work with. I think some of these we may want to steer away from, like calcium hydroxide. We'll cover that. But let's go through these materials and look at them from the past and then move forward and look at to the future. The AAPD guidelines also covered adverse events. So that will be more something you want to pay attention to with the ferric sulfate if you're using that. Type of final restoration, that's something that's going to be changing here with our new guidelines when you're using a calcium silicate, of course, and then, of course, the use of the rubber dam as the gold standard. This all starts out with a diagnosis, and this is really difficult in kids, but we really need to focus in on this to be able to have a good outcome with indirect pulp therapy, as well as our pulpotomy. So these are the AAE pulpal diagnosis here. So we're going to be looking at normal or reversible pulpitis for vital pulp therapy. When we get into these irreversible pulpitis, that's something we're seeing more in permanent teeth. Now you can do vital pulp therapy, but that hasn't translated over yet. We haven't seen anyone do studies with these calcium silicates in teeth with irreversible pulpitis on primary teeth. I think it may be probably now should be better termed acute pulpitis rather than irreversible, but we'll see what happens with the AAE does with these new studies, because in permanent teeth, we're seeing on these permanent molars, you're able to do a calcium silicate pulpotomy and avoid a root canal and save the tooth. So we'll see where this goes, but we want to mainly focus on those top two. Again, we want to have normal apical tissues. Definitely we don't want to have inflammation in the root or have pulpal necrosis. Those are things that are not going to work out for our pulpotomy. here's our laundry list. I'm going to work through this because I like pictures a little bit better. So here you can appreciate we have a young individual that has a few deep carious lesions. Potentially some of these could be benefit from a pulpotomy. We don't want to have swelling. So we don't want to have this here where we have a lesion and we have an acute apical abscess. That's going to be a sign of necrosis with this tooth. You don't want to have a sinus tract here. You can see one probably associated with tooth number G, but that's something that's not going to be a candidate for vital pulp therapy. We don't want to have spontaneous pain that's getting the kid in when they're in school, getting them into the nurse's office, not being controlled by Tylenol or ibuprofen. We don't want to have history of pain. Something you want to ask about with kids. It may have been pain a few weeks ago and they're in your office now because there's a little bit of weight, and now the tooth's dead and there's no pain. So you want to ask the questions about the history of the tooth and make sure that you're using all the factors. It takes about 6 to 8 weeks for any pathosis to show up on your radiographs. That's why our guidelines when we have trauma are at those standards, because they'll catch those things. We don't want to have mobility, especially like you don't want to be doing a pulpotomy on a loose tooth, but that could also be a sign that there's inflammation in the PDL and it's moving a little bit more. We don't do vitality testing or sensibility testing with primary teeth. So you're just mainly going to be using your subjective and objective findings from your exam. We do percussion and palpation. Those can be things that will tend to, when you push on the tooth, you may have some response from the child, and that may be a sign that there's some inflammation going on at the end of the root. We don't want to have any apical pathosis or furcal pathosis. Here you can see this one here associated with tooth number S, a large lesion. This one is not going to be a candidate for a pulpotomy. That's probably something we're going to be looking at doing extraction in a space maintainer. You don't want to have a widened PDL. One tip I have for you on these, if you have a situation where you have something like this and you're not sure, you can put a temporary glass ionomer in or do a temporary Hall crown if you have something that you can't get the glass ionomer in, and have them back and see if that helps. If it helps, you may have a sign of reversible pulpitis, and if it doesn't, you may have a sign, well, you need to go ahead and move forward. This one ended up having irreversible pulpitis when we put the SDF and a glass ionomer in. We called them the next day and they were still having pain, so we went ahead and extracted that tooth. No calcifications. This one is kind of a little bit of a head shaker for me, but I think the reason behind this is because if there's calcifications, there may have been prior damage to the pulp, and the thought may be that there's less of an ability for it to go ahead and heal. What do we have to have calcifications? We have to have vital tissue. So the pulp does have a response. I kind of take this with a grain of salt, but here you can see calcific metamorphosis on tooth number F, and that's kind of one thing you might want to consider is prior trauma or prior carious insult to the pulp. Adequate remaining dentin thickness. This is huge. So you ideally want to have in primary teeth 1 millimeter and permanent teeth 0.5 millimeter. Here you can see on tooth number K, we don't have that. This is kind of, when I get to my diagnosis of reversible pulpitis, this is kind of what I look to when I'm determining if I love doing indirect pulp therapy. But if I don't have that remaining dentin thickness, I'm more leaning towards the pulpotomy. Unless it's just one tooth and we have behavior issues, we may put in a temporary, like I said, and see how they do. And then if that's working and we go 6 to 8 weeks and get the x-ray and things are fine, then maybe we move forward with the Hall crown. That's kind of one situation where I kind of bend things a little bit. But yeah, you definitely want to have a thick band of dentin there. Again, you want to have healthy pulp tissue. Here you can see a tail of 2 pulps. One of these looks great. One of these is bleeding quite a bit. So that bleeding can be a sign of irreversible pulpitis. In this case, we ended up extracting tooth number K, and then L, we move forward with the pulpotomy. Again, if you're uncertain of a diagnosis, this is one I didn't know what I was looking at here. So we've got tooth number L, we've got a deep carious lesion here, and we don't really see anything here on our periapical in the furcation. And I wasn't certain. So we planned this for extraction and a pulpotomy. And then here's what I encountered when I entered the pulp. So we didn't have any bleeding. So this is why sometimes it's nice to be able to plan for both and do your caries removal for a diagnosis. I got in here, we found out this was a necrotic tooth. We're not gonna have too much value with that first molar. If it was a second molar, I might do a pulpectomy, but we can do a spacer and abandoned loop. But this one, we went ahead and went back and we extracted this tooth. So just one thing, you can always plan for different things here. I was going to go ahead and extract it. I went ahead and I had done a filling on the other quadrant. I had some Riva self-cure HV left. I went ahead and put that in so I didn't fracture the tooth when I was extracting it. So if you got some extra material, that can be one thing that can be useful so you don't end up fracturing a tooth that you weakened by removing all the tooth structure. We're going to move forward here. So let's move into indirect pulp therapy. I do a lot of this at my office. I love it. I think it works great. Do a lot of Hall crowns. Probably wouldn't practice without a Hall crown. I think it's one of the best things we have for especially a little anxious kids that have some lesions that aren't enough to justify sedation for. But we got to remember what causes the problem for us. It's bacteria. And if we don't have bacteria in the pulp has an amazing ability to heal. This is kind of the gold standard from the endodontic literature. They looked at rats that were germ-free and rats that had bacteria. They fed them both germ-free food, and they had to cut off their incisors and let the pulp be exposed. And then they euthanized the rats and looked at the teeth under a microscope, and they found that all the rats that were germ-free, they still had vital pulps. They still had some inflammation and food impaction, but they had vital pulps. All the other ones had inflammation and then some necrotic pulps because of the bacteria. And they determined the major determinant in pulpal healing is the presence or absence of a microbial flora. And that's why the rubber dam is so important. And I think that's why these calcium silicates are working so well. And that's why I think our Hall crown works well. Our indirect pulp therapy works well. We have the same thing with our teeth. So we have bacteria in different levels. We can have it infected bacteria in the dentin. We can have a sub area under that where we have affected dentin where there's no bacteria. And then we have this kind of thing we never know how much we have, remaining dentin thickness. And how big of a wall do we need between the bacteria and the pulp for the pulp to be able to stay alive? And that's 1 millimeter in primary teeth, half a millimeter in permanent teeth. And this comes from just taking teeth out and looking at them under the microscope that have carious lesions. So this was done in the endodontic literature back in the 70s. And on the ones with superficial lesions, when you start to get a cavity or you get reversible pulpitis, the pulp does respond if it's in the outer area of the tooth. You get changes in the odontoblast layer, but mainly the pulp remains unaltered underneath that. As we start to get more deeper lesions here, you can see they looked at 11 of these teeth. They started to see inflammation start to take place in the pulp, and they started to see changes in the odontoblast layer, getting a reduction in numbers. As they got deeper, we started to see that reparative dentin, inflammation, loss of our cell-free zone, and then this is key for the pulpotomy. When we get to that point, we have the radicular pulp appear normal or less involved. So that's why we can do a pulpotomy in the tooth that doesn't have remaining dentin thickness, because the pulp in the roots is still healthy and viable. We may have that infected area at the top, but we can get down to a healthier area. Indirect pulp therapy started back in the 60s. And this was in primary teeth. They looked at re-entering these teeth after doing indirect pulp therapy on these 30 molars. And they found out 93% of these teeth after leaving decay, when they went back, were bacteria-free. All of them had hard, shiny dentins. And the radiograph showed reparative dentin. Again, looking at different materials. And this hasn't really changed for indirect pulp therapy. We'll see if it does with calcium silicates. We'll see if it does with SDF. Those are some things to look at. But looking at the material, they did these with IRM, indirect pulp therapy. They did some with calcium hydroxide and IRM. Reduction in colony-forming units in both the groups. No difference between dical and IRM. They concluded the re-entry may be unnecessary provided the coronal seal is intact. And I think we're seeing that with our Hall crowns. We're seeing that with our permanent teeth with indirect pulp therapy. Again, here, calcium hydroxide, an RMGI, and two RMGIs, reduction in colony-forming units, no difference in the final colony-forming units between the groups. If you don't eat, you die, is kind of how I explain it to parents. You're sealing off the bacteria. They're not getting the substrate, and they die. Looking here at remaining dentin thickness, this has been done, I think, in 2 studies now. So this was looking at, they did a pulpotomy and they took that pulpal tissue out and they looked at remaining dentin thickness and the radiographs and determined at what point did that pulp have inflammation that was unable to heal. And they found out you want to have about 80% of remaining dentin thickness and you want to have a greater than 1 millimeter. And this has been replicated in one more study now. So that's kind of where I look for that thick band of dentin. And again, if you're not sure, complete caries removal. If you have behavior issues, either a temporary Hall crown if you can't get the glass ionomer where you want it because it's an interproximal lesion, or if you have access to glass ionomer over that. If we look at indirect pulp therapy, pediatric dentists love this. I mean, like most of our work falls out, right? So most of it's on baby teeth that falls out. I still do a ton of it on permanent teeth. I think it's kind of where things have been moving as preserving tooth structure, and SDF has been a part of that with the SMART technique. I think it's been a great tool, but we can also see there's a variation. Endodontists practice complete caries removal about 70% of the time, and general dentists are somewhere in between. Endodontists, they get paid to put a white line in a tooth, right? So our reimbursement structure is not, it's kind of driving the treatment that we're doing. We're not getting paid for direct pulp caps because it's inclusive of the restorative procedure. We're not getting paid for an indirect pulp cap because it's inclusive of the restorative procedure if you're in network with the insurance. So that kind of ties things up with us as far as reimbursement with some of these calcium silicates, which are great products. Here, looking at glass ionomers for deep carious control to diagnose the pulp. This is what I was talking about. If you're not sure, put that in, have them come back, call back the next day. See if they're in pain first. If they're still in pain, then have them back and get the treatment done. If they're doing well, then have them back in 6 to 8 weeks. If you're not sure, get a new x-ray, and that's going to improve your success to help diagnose the pulp. Also here, looking at indirect pulp therapy compared to a pulpotomy. Mind that these were formal creosol and ferric sulfate pulpotomies, which are not the gold standard. Formal creosol, very, very good, very high up in success rate. But indirect pulp therapy has been shown to have a lower cost and higher success and better exfoliation pattern than treating reversible pulpitis with a pulpotomy. And I think you can do both. And I think you can't, if the bacteria has gotten into the pulp, you're not going to be able to do indirect pulp therapy. I think that's why both of these are only ever going to be 90% successful, because we're never going to be able to make that accurate diagnosis all 100% of the time. So that's something to consider. I think they're both great, but here at 2 to 7 years, this study, again, formal creosol versus indirect pulp therapy, 93% successful, which I think is great. And here you can see the formal creosol pulpotomy, 74%. This is not the best study, because if you look at the pulpotomies, they weren't all restored with a stainless steel crown. I know that's going to change with our new information that we're going to go over today, but the stainless steel crown really works well. And if you can get that on there, or a zirconia crown, if they want to have aesthetics, that can be a better way to protect that and seal the tooth in. Remember, the coronal seal has to be intact for both of these to work. I think that's why with the calcium silicates, some of the things I'm going to show you with these biodentin and how the mineral tags form the tooth and they entomb bacteria, it's just going to be kind of makes sense on what we're seeing microscopically of why the calcium silicates work so well. Again, here it's from the AAPD from back in 2020, looking at the numbers here for indirect pulp therapy. Great success. And here again, at the bottom, all liners equally successful. Calcium hydroxide, bonding agents, RMGI. As long as everything remains sealed, right now we don't have a material that's going to push things over the edge, and we're going to be very, very successful with this if you have the right diagnosis and you have adequate remaining dentin thickness. I love it. Again, success of indirect pulp therapy was independent of the type of material used. Again, conditional recommendation with moderate quality evidence and moderate quality evidence at 24 months and low quality at 48. So this is the biofilling that I'm talking about. This is exciting to me. So this is a calcium silicate product. I'm gonna play this video. And this is happening with, I've seen it with the biodentin, I've seen it with other calcium silicates microscopically. This is what's happening inside the tooth when we place calcium silicate or an MTA. Tricalcium and dicalcium silicate are what you're actually looking for here. So this they infected with E. calicis, bacteria known bioceramics to be a nightmare to disinfect and a big problem for endodontists and root canals. And you can see the calcium silicate penetrating into the dentin tubules, forming tags and tuning the bacteria. And when we look at the seal, it's really nice to have that confidence that a product that you're using, even if there are maybe some bacteria left, you're entombing them and you're also plugging everything up. So if there is loss of your restorative seal, you still have an amazing interface contact tubules, and the tube have a better protection. I think this is why we're seeing such a high success rate with calcium silicates, vital pulp therapy, permanent teeth, and primary teeth now. Our new recommendation is to use calcium silicate for pulpotomies. And I think if this is happening, maybe this could be a benefit for indirect pulp. We'll see. Someone needs to go out there and see if this is going to be better than one of those other materials, because we haven't really seen those been tested. Moving into a direct pulp cap, I don't do a ton of these. You might do one when you have a whoopsie, but the indication may be a mechanical exposure, pinpoint exposure, and following you want to place a biocompatible material. Back here in 2017, when moving into the 2020 guidelines, they looked at calcium hydroxide versus alternative materials, which are calcium sulfate, formal crystal bonding agents, and MTA, and they really couldn't find a difference in these. There are various ones that can be successful. I think probably you're better off moving to the pulpotomy in most cases, unless it's a conversation where you're looking at doing a DO resin. You have a pulp exposure on a primary first molar, and it's now you all of a sudden have to go over the cost of an additional procedure of a pulpotomy and a crown. That may be a tough thing to swallow for some of our patients, especially if they're on a budget and they haven't planned for the additional cost of those procedures. Again, here, calcium hydroxide versus the alternative materials. In these studies, they found that qualified. They couldn't find a difference in these materials for the direct pulp cap. Again, success of the direct pulp cap was independent of the type of medicament used for the studies that they looked at. Moving into the pulpotomy here are the materials they looked at. Let's move into these. And this first one kind of got me head scratching, because MTA, and then down there they have tricalcium silicates. Well, MTA is a tricalcium and dicalcium silicate. So I think we got it right here in 2024, and we grouped everything together. But I think there's a little bit of a misnomer between what we were looking at as far as materials and their success. And really what we were talking about is calcium silicate cements when we're talking about these products. And they're great. MTA has some huge advantages over calcium hydroxide: faster bridging, bioactive, biocompatible. It's going to have a good pH, alkaline pH for bone formation or hard tissue formation. We need that. Traditionally, at a long setting time, we're not seeing that. Now we've got products 9 to 12 minutes. Biodentin, difficult handling. It was a powder liquid. I'm going to show you Biodentin XP. Some of these other ones like Neoputty. I mean, the stuff is just, it's kind of like anybody could do it now. Cost can be a concern, but now we have all these competitors, so things are kind of coming down. Staining was a big concern with the traditional pro-root MTA. You don't have that anymore with these newer products that don't have the bismuth oxide in it. We've got nice products like Biodentin that are out there that you can use and not have the staining, especially on a young kid with a complicated fracture of 8 or 9. I mean, what better way to build your practice than to be able to build that tooth up, avoid a root canal, and it's such a successful procedure and such a game changer for your office to take a young kid in a time of need and change it. And I think that carries over to primary teeth, but that's I mean, it's going to be hard to get a job without a front tooth. Again, these were about 89% successful, and that's kind of similar to what we're seeing with indirect pulp therapy. When I look at all the studies for indirect pulp therapy, and I look at all the studies where calcium silicates, we're seeing about a 90% success rate. So pretty good stuff. I would say that's 90% is pretty good in dentistry. Dentistry is a tough gig, especially on kids. Again, they recommend the use of MTA. This is going to come back when we go over the 2024 study here. Formal creosote, very popular, probably the gold standard for a long time. I know you're not able to get some of it now. Some Sultan Healthcare stopped selling formal creosote, so going to be a little bit harder to access. This works by essentially killing everything. It mummifies the pulp. You leave a little bit of radicular pulp tissue at the end of the root. And there are some concerns, toxicity. This is from the study out of Indiana where they looked at the zones of former creosol and what happens. So histologically, you can see where the pulp, we have that medicament, and then we have the zone of coagulation, necrosis, the transition zone. And then here at the end on the right, this after 41 days, you can see that vital tissue. And that's why we're having success with this. We're killing all the bacteria. We're leaving healthy tissue at the end of the root. Now, my question is, what happens when this tooth starts to resorb? What happens when that vital tissue is gone and now we're in contact with necrotic tissue? Why do you think pulpotomized teeth have exfoliated sooner than their counterparts? Do you think there's some chronic inflammation that goes on once that vital tissue is gone? I don't know. That may be the reason. I'd like to see that study redone, a pulpotomized tooth with a calcium silicate versus a natural tooth. I'm actually seeing my pulpotomized teeth with calcium silicates last longer than the contralateral tooth. And in some of these kids, just anecdotally looking at when I have one fall out, when I'm looking back at the records and I see, oh, I kind of question that in my mind, but we'll see if someone wants to do that study. I think that'd be an interesting one. So just a comparison here on the left, the former creosol pulpotomy versus the calcium silicate pulpotomy. We're actually leaving the whole root healthy. That whole area I talked about where the radicular tissue after on those deep lesions is still healthy. We're leaving that whole root healthy. And I think that's a great thing for our patients to do. I think that's why these are really working so well with our young patients. Concerns that this is in the CDA in 2010, I believe, concerns about former creosol. I think it's very safe to use in kids. Looking at the studies, we have a great way to look at this. This was done in animals. They did former creosol pulpotomies in dogs and looked at them. Afterwards, they found formaldehyde and creosol in the blood, the lymph nodes, the kidneys, and the liver. When we look at kids, we take them to the hospital, and what do they do when they start anesthesia? They put in an IV. So they looked at kids undergoing former creosol pulpotomies. There's two great studies here. Drew blood samples and analyzed them when the kids were getting pulpotomies. They didn't find any elevated formaldehyde or creosol over baseline in this study of these kids and these other 25 kids with 106 pulpotomies. Same thing. This is safe to use if you want to use it. I think there's better options out there, but by all means, if this is what you've been using and you like it, it's a great option to be able to save teeth. You're gonna have great success with it. And I always kind of scratch my head. I mean, we got all this now drama going on with fluoride in the water and BPA in our fillings, and I can't believe this hasn't gotten out. I just have always scratched my head why these moms have not. Could you imagine if they found out that people were putting former creosol in these kids' teeth? Like, what would be there'd be like a heyday. I mean, way worse than some of these other concerns that we have out there. But I guess it hasn't gotten out yet. But I just think it's kind of crazy that hasn't been figured out, that's been a material that we've been using. There haven't been more concerns about it. We're lucky in that matter. Back in 2020, they did recommend the use of former creosol. I think you should still use it today if you're not ready to make the jump to calcium silicates. Ferric sulfate may be something you want to use instead if you're not wanting to have those concerns with toxicity and carcinogenicity. I think sodium hypochlorite is another viable option alone. That's a great option as well if you don't want to use former creosol and you don't want to use a calcium silicate product and you don't use ferric sulfate because obviously ferric sulfate has been historically known for internal resorption concerns. We know other medicaments are superior, former creosol and MTA. And this one you really got to watch your water lines. You should be watching your water lines anyways, testing them and treating them monthly, testing them quarterly. This Anaheim clinic unfortunately did not. They did former or ferric sulfate pulpotomies. They had bacteria in their water line, and unfortunately, quite a few of these kids ended up hospitalized with sepsis after having been infected from the water line. So what happened was the ferric oxide in the ferric sulfate will make these bacteria superbugs, and when you combine that with a dirty water line, you run the risk of causing sepsis or an infection. So just make sure you're doing your water line testing. Super simple. We do these at my office. We perform the monthly maintenance and then also the shocks when we need to. If you want, you can also do an in-office test or mail-in testing if you want the actual count. This one doesn't give me the actual count, but it can give you a chart to compare it to. So just make sure you're staying on top of that. Super simple for one of your team members to be in charge of, have an infection control manager to do the sterilization monitoring, this, and just have one other person that knows how to do it in case they're out on vacation, so you're not dropping that ball. Again, the panel did recommend the use of ferric sulfate back in 2020. Lasers have been thought to be good. I know some endodontists will actually use these as well. They can be used for sterilization. They're thought to have a stimulative effect on the pulp cells. But when we look at these histologically, we're getting chronic inflammation, and we're not getting the same bridging that we're getting with the calcium silicates. So the panel did recommend the use of lasers. That was a conditional recommendation. Sodium hypochlorite, that's a great option. Just this alone in IRM, you're going to be pretty successful, 80 to 90% successful with this. It dissolves organic matter. It's antibacterial when we're looking at getting the bacteria out of the pulp. Very cost effective. They just cited limited studies, but they did recommend the use of sodium hypochlorite. Got a question this week online, what percent to use? 3 to 6. I use 6% before my calcium silicate. 3 is probably more in line with the literature. Higher concentrations are more cytotoxic to pulp cells. So probably looking at a 1 to 3% would probably be more appropriate in your use in your practice. Tricalcium silicates. So these are the tricalcium and dicalcium silicates. So this is like the Biodentin, the Neoputty, these calcium silicate cements. They separated these out. These advantages, the placement's going to be so much easier than traditional. They have the same properties. There's not a lack of research with these now. We have the research to show that these are very successful. Been using them for a lot of time, and a lot of great studies with a lot of different materials out there that just going to pick on what you want to handle, how easy you want, and then your cost and the system you want to use. So they did recommend the use of the tricalcium silicate for pulpotomies. This might have surprised someone, calcium hydroxide. This one here, long time. I think the market a few years ago for calcium hydroxide was $3 million in the US, is what I heard from one of the reps, and I couldn't believe it. My jaw almost dropped with all this stuff coming out with the MTA products and the calcium silicate products. But this works by causing a zone of coagulation necrosis, and that irritates the pulp to heal. Again, this has been used for a long time, but what the problem is, at 2 years, 89% of these have tubular defects. There's holes in them. If we want that nice microscopic thing I showed you earlier in the lecture, the calcium silicates deliver that. They deliver that entombment. We don't have, they entomb, they go into the tags. And I think it's a no-brainer that they're a better product. But here, they recommend against the use of calcium hydroxide for pulpotomies in primary teeth. Might be a surprise, but calcium hydroxide is no longer, as of 2020, recommended. Other factors, huge one here, rubber dam. Please, please, please use a rubber dam. I would love to see an isolate study. Some residents should get on that, do isolate compared to rubber dam. But please, it's a gold standard. And if we're looking at keeping all bacteria out of the pulp, the rubber dam is going to do the best job of everything, retracting the tissues, all this stuff. So let's move through this list. If you want to take a screenshot here, we're going to go through each one of these on our list. But isolation, this is key for our pulpotomies. You're not going to have saliva get over or the kid's tongue move over. You're trying to isolate it and do a nice job with disinfecting, and then you're putting your calcium silicate in, and then all of a sudden, right before you're putting that in, you have kid get a big ropey saliva come in, and you lose that isolation. We know we don't want to have bacteria in the pulp. We want to keep it as clean as we can for the best chance of healing. Visualization, love this. I use a microscope now, and when the rubber dam's on, I can see so much better. I can see what I'm doing, get nice contrast. With kids, it's nice. It retracts the tissues. You're not going to be getting a tongue in your burr. You're not going to be getting a cheek in your burr. And then your material properties are going to be so much better. You can actually control the environment you're working in. If you want to have that dry, sandy feel for your bonding agent to work, you're going to be able to have that kind of hydrophobic application versus having a bunch of saliva. So your composites are going to be so much better, and you're going to be able to have a nicer outcome for your patients. Airway protection, you're not going to end up sitting a kid in for a chest x-ray from swallowing something. I've done that twice, and it was not a pleasant experience to have to go through that and send the kid into the hospital. One kid swallowed a tooth and we couldn't find it, and the other one was a sedation where they had the same issue. So being able to protect it that way. Behavior management, if you got a chatty kid, it's going to help make them not talk as much. They're going to be able to have that, and they're going to be able to talk to you as much, which can be a barrier for communication. But if you got one that's chatty, it can help with behavior management and getting them to also breathe through their nose. You can have that help potentiate your nitrous. If you're a big nitrous oxide oxygen user, can make them an obligate nose breather, and that will potentiate the sedation as well if you're using sedatives. I know a lot of times I don't do oral sedation anymore because it's not predictable, but when I did do it for the few years I was doing it before we had our anesthesiologist come in, a lot of times we would just once we got the rubber dam, I knew if I could get that on, then waiting a few minutes, I could get that kid to the point where I could work on them. So definitely does help with your nitrous oxide. And if you're doing conscious sedation, it can help combine those drugs and make them work well. Some people may not be able to tolerate claustrophobia, may not be a candidate for a pulpotomy if you can't get that on. This time of year, gosh, we've had so many sick kids at my office. You're not going to you're already doing something that's uncomfortable, right? Dental work, we can all agree, maybe it's a little uncomfortable. I've had it done to me. And then you're all of a sudden, they have a stuffy nose and you're putting a rubber dam and they can't breathe. We're going to make it more uncomfortable. So just something to keep consider. I think that's one of the greatest things that came out of COVID is we don't work on sick kids unless it's a dire emergency. We can reschedule those out a few weeks and make the kid a little bit more comfortable. Some kids have a gag reflex. They may not be able to tolerate it. It may not be a pulpotomy, or may not be a procedure that you want to undertake on that kid if you're not able to isolate properly. These are some of the retainers I like. 27N is a great one. It's a premolar clamp. You can really use that on both arches. Works really well on those maxillary second molars. And then on the mandibular, a W3 or W8. And then if you have a tooth that you're like trying to do heroics on and it's broken down, the W8A is a nice retainer to have in your kit to be able to put that on a severely broken down tooth. We do a lot of Telstra as pediatric dentists. You all know this very well. Jewelry, what girls don't like the jewelry of the tooth ring. We tie whisk floss onto it, so we ligate it so we don't lose it if it pops off. Use their favorite animal for that, or if they have cats or dogs, you can talk about that. The rubber dam, again, I'm usually doing a slit dam with their Mickey Mouse, so you can show them the Mickey Mouse, and then you can put this on their finger and show them what it's going to be like. A lot of Telstra do. Final restoration, they also looked at. This is something that's going to change. So they recommended if it's going to be 2 years and it's not intracoronal, they recommended going ahead and doing a stainless steel crown. Nowadays, with the new study here in 2024, you're going to see this change. And I think that's when you're using calcium silicate, I think is the intent for that, because you saw what happens microscopically. They're going to seal so well. This is one that, unfortunately, this kid I didn't do this one, but this kid had a pulpotomy, ended up in the hospital with an infection. And I don't think this was a calcium silicate pulpotomy. I don't see that material there. I wasn't there, obviously. But we don't want to be having that kind of outcome. We want to be able to be successful. And here's a situation where I had a whoopsies and I had a pulp exposure. I was planning on doing just an indirect pulp therapy here with a DO and just charging a sedative filling for this kid here on tooth S. Ended up having a pulp exposure again on those primary first molars. Got into the pulp there. Didn't want to really go into have the conversation of now we're doing a pulpotomy and a stainless steel crown on your kid when we were planning on doing a temporary filling. Like, whoops, that's not a fun conversation to have. That's something you should talk about beforehand, which we're going to get into next. But I went ahead and did the pulpotomy and just did a DO on that. So a calcium silicate. And here we are on our recall and ended up working out fine for us. And that tooth actually exfoliated fine on its own now. Someone posted online, I think it was on one of the Facebook forums I saw this week, about having treatment and having it fail. And one of the things, I think the biggest thing in talking about this is informed consent. And I think one of the things that I found is it's a lot easier to have the conversation about what could happen beforehand than trying to explain it afterwards. And I think part of that goes into informed consent. I think when we are talking about these deeper lesions, whether you're doing indirect pulp therapy or you're doing a pulpotomy, it's important to have, I almost always have the conversation that we may have to extract the tooth if we get in there, because sometimes I showed you that video earlier. And then I think it's important to have a conversation that this is a really deep lesion. This tooth is severely damaged. We're going to do everything we can to save it. But there's a 10% chance that this won't work out. This is a biologic procedure and we can't make any guarantees, but we want to save this tooth. It's a space maintainer. We want to save it for function, and we don't want to have to deal with space maintainers long term. I think Yappy does a great job. I've given Yappy consent for a pulpotomy. If you're doing vital pulp therapy, you may want to contact Adam for that, but you can tie that to the procedure. We use Yappy. I love doing this for our new patient forms because everything gets sent into automation and it comes in automatically. Here you can see medical and dental history. All this gets brought in when they get a new patient form at my office. All of my 3 documents get sent to them in a text. They fill that out. It gets brought right into Open Dental. It populates all the alerts in Open Dental. It'll even collect their insurance information and their pictures of their insurance card as well. But this is a way you could do it. You could add this to your procedure on your consent forms if you want. So you're streamlining your process at your office. And I don't do this for I don't have a consent form for every single procedure. Obviously, extractions are one you're going to want, and then endodontic therapy is another big one, and then any sedation are kind of ones that are a little bit higher risk, higher medical legal aspect. But we do have our treatment. We have a little blurb at the end that they're approving this treatment. But it's a great way if you really want to get in and tie all your procedures and link everything up. You can do that, and it's a great way to streamline patient intake. No one wants to have that new patient come in. They're scheduled at 8. They don't have paperwork done, and by 30 minutes later, they're already half an hour into their appointment, and you don't have time to do everything you want to deliver in that new patient experience. So encouraging these people to get this done beforehand is key. And if you want the pulpotomy consent form, by all means, contact Adam, and they can get this done either at home, or you can have them come in the office and do it on your iPad or on a computer if you have that set up. So super simple. And we have our packages set up, and it's just been a game changer for us to be able to have that set up for consent at our office here. Criteria for success here. Let's move through this quickly. These are our criteria. I'm going to move through these. Again, this is a laundry list. If you want to snap a picture here, we'll go through all of them with some pictures. So here you can see these are some deep lesions here. Here you can see on tooth number J, I showed you this one earlier on K, and tooth number T. You can see these ones end up treating, these were biodentin pulpotomies here, end up treating those here and having a nice outcome here a few years later for those kids moving through. We don't have any symptoms afterwards. If they come in pain, we want them to leave fixed pain-free. So we want to have a happy outcome. We follow up on all our patients at our office that get local anesthetic the next day, give them a call, see how they're doing. Great tip for your practice builder. You may want to see if you're using calcium silicate, this dentin bridging. Here's one. This was a calcium silicate pulpotomy. Here you can see a nice dentin bridging. That's just a nice celebration for you and your staff to see. We want to avoid this. I don't watch this in my office. I think a lot of people are inclined to watch rarefying osteitis, but I think as we learn more and more about the oral health connection to the body and chronic inflammation, I wouldn't want to leave chronic inflammation in my mouth. And when we look at this as a tooth I extracted, you can see there's pathology here. If something doesn't work out, I just am honest with my patients. It didn't work out. And here's now how we fix it. And, it's not something that I really want to watch at my office and just leave that chronic inflammation in a kid with all the things we're seeing with inflammation in the body these days in the research. No harm to the succedaneous tooth. So here's one easy crown with a pulpotomy here. Really nice outcome all the way into that child's teen hood. We're able to save that, maintain the space. We don't want to see external resorption here. These are some that I did that failed. This is back before I was using calcium silicates. We don't see this as much. This one didn't have a pulpotomy. This one had indirect pulp therapy, but we don't want to see internal resorption. You can monitor that until it perforates, but that's something that we really don't want to see. Again, here, this is survival. Here you can see tooth number T and I here had pulpotomies, and just rarefying osteitis not working out. And I'm sending this over to the radiologist at the University of Iowa. And this is what the radiology report said. Rarefying osteitis in the periapical regions of the Primary molars, there's discontinuity of the cortex around the dental crypt of the maxillary left permanent first premolar. There's appearances suggestive of a secondarily inflamed hyperplastic follicle. So inflammation possibly impacting the adult tooth. When things don't work out, we just need to kind of admit that. These are some of the other uses for calcium silicates. You can use them for indirect pulp therapy, direct pulp cap, like we talked about earlier, a full or partial pulpotomy. Not really going to talk about apexification. I've done that in teeth, necrotic teeth with a missing succedaneous tooth. I've done that a few times. And then hopefully you're not having a perforation, but you could use it. These are some of the products that are out there. Obviously, Brasseler's got a really nice product that all the endodontists use that I can't afford. I tried it once and I put some of that in a tooth, and I was like, holy cow, that was a pretty expensive primary tooth. I just did that too. Not fee for service. So some of these other ones you might want to look into, Neoputty, the Edge Endo. Biodentin's a really nice product because you can actually use it as a temporary restoration. I've been in situations where we've had a kid lose it. I was able to complete the pulp therapy and leave that permanent tooth and come back and fight another day. Really nice case I had on a special needs case that worked out well. We did not have to do root canal therapy on that young adolescent. Biodentin XP, kind of the next generation. I'll show you the application of that here in a video. If you're doing primary teeth, you're going to want the 200, a little less in it than the 500, but that's going to make it go farther for you. Again, some of the properties here as we move through, it's going to be faster bridging, bioactive, they're biocompatible. We don't have the long setting time. We don't have the difficult handling anymore. We are driving down the cost and we don't have the staining. So these calcium silicates have really exploded the market. I don't know of too many people that use ProRoot MTA anymore. And that wasn't the case probably 10 years ago. This is, again, Biodentin. You can see it's doing the same thing that I showed you microscopically. We're getting those tags with the calcium silicates going into the dentin tubules. We're getting the dentin tubules filled up with calcium silicate. And that's creating a great seal. Traditional setting time of ProRoot MTA was 2 to 4 hours. Back in residency, we'd leave the MTA and put a wet cotton pellet in and have them come back to do the final restoration. What do you think happened after you got them out of pain and you put the cotton pellet in there? And they didn't come back. You got them out of pain. So nowadays we're restoring the same day with these fast setting ones. Here's just a wide variety of the products out there. Obviously, it's going to vary on what you use, but anywhere down 9 to 12 minutes with Biodentin, getting down to 20 minutes. So you can really use these products and restore the same day nowadays, whereas the traditional ProRoot MTA you might have a little more difficulty with. Biodentin has some similar properties, but I think one of the neat things about the Biodentin is the higher concentration of calcium silicates compared to ProRoot MTA. So if you look at the traditional ProRoot MTA, you got about 66% tricalcium. The Biodentin, you're up to 80%. And I just think having that material, that active ingredient at a good concentration makes the product work really well. Again, the working time for Biodentin's around 5 minutes. Setting time is 9 to 12. Originally, this was titrated. Takes about 30 seconds, so it may seem like a long time, but that's a nice time for you to be, if you're using the old version, to be able to go ahead and put in your medicament, your chlorhexidine, sterile cotton pellet, or sodium hypochlorite. This is the capsule that comes in. You're going to want to tap it if a few times or open it and mix it up just because it might have settled. That's going to give you a more consistent mix. If you're using the older version here, again, you could also open it up. And then you're going to do your drops of this is a calcium chloride or the liquid that's going to help with the setting. And then again, it's a 30-second titration, and it's going to come out with a nice putty form. If you're using the original Biodentin, I just picked that up with an amalgam carrier. If you wanted to, you could use a plastic instrument. But nowadays we have the Biodentin XP, which comes, and you're just going to apply this directly into the tooth. Super simple. I'm going to show you a quick little video here of just the two different ones, the amalgam carrier with the traditional, and then we'll show the Biodentin XP, just the difference in handling. And I think it just makes it easier, more desirable to use. We talked a little bit earlier about the staining, but what happens when bismuth oxide or the radio opacity agent that's in the ProRoot MTA comes in contact with sodium hypochlorite, it causes a staining. These newer products, they have a different one. They have zirconium oxide and titanium oxide in them for radio opacity, and you're not going to have that dark front tooth or that dark tooth, especially if you're using this for vital pulp therapy in adult anterior teeth. Difficult handling. A lot of that's gone away with these newer materials. This is my first attempt at MTA. Yeah, not very good here, but you can learn. Here I got better. If you're using a hand mix one, this is forward MTA at the time in residency. Just a little video on mixing this. A little bit, I use local anesthetic. I'm using one of these, a little bit out, mix that up till it feels like you're playing with the sandcastle on the beach. I say if you can build a sandcastle as a kid, you can handle traditional MTA. Now, if you want, go ahead and use the putties, use the biodynamic speed. You don't want to have to deal with that, but it's super simple to get to that end of that sandcastle consistency where you know it's going to stick together. And then using the amalgam care. A lot of us probably don't use amalgam too much anymore, but the amalgam carrier is probably my MTA carrier now. But easy application to the tube, and then damp that down with a cotton pellet, and pretty simple handling. We're in an APD in Hawaii a few years ago, and here you can kind of see the variations. You want to be in the middle. These two in the middle. You don't want to be too dry where it's not going to stick together, and you don't want to be too wet where it's just going to run all over. So that sandcastle consistency, super easy to handle these materials. Again, cost is going to be different here. Just different costs of different materials. This is back in 2017, I believe this is from. This is going to be a little bit different, but you can see cost is going to range. So let's walk through a pulpotomy here. Typically, I know at this point, I've got reversible pulpitis, or I'm doing complete caries removal for my diagnosis. So I know I'm going to be performing that procedure. So I'm going to go ahead and do my occlusal reduction here. So this is on A and B, and I knew I was going to be performing the pulpotomy. If I know I don't have remaining thickness, I'm not going to go back and forth with the round burr. I'm going to go ahead and take a football diamond. I'm going to go ahead and remove the decay, and then I'm going to de-roof until I see the pulp, until I see that pulp horn exposure, and then I'll switch out to a more conservative burr. This just speeds up my procedure time, so I'm able to keep that short for these kids that might be a little bit more apprehensive or wiggly, and I know I'm going to be able to work faster and get that kid comfortably in and out of the chair without spending a long time having a rubber dam on and sitting there for a procedure. So here you can see we removed the decay. Here you can see we're starting to see the pulp exposure. So I'm going to switch out. I usually use the 2 round burr at this point, and that's what I'm going to use so I don't perforate. So I'm going to go ahead and de-roof the chamber at that point. And then I don't like taking a burr down into the pulp orifice. You can if you want. Some people use a slow speed on reverse with the round burr. I typically will go back to the spoon just because I don't want to perforate. So once I get that de-roofed and exposed, I'll go back here with a sharp spoon excavator. And it may take a little bit more time to do this way, but I have not perforated primary molar in a long time. So just being a little bit more conservative with the spoon here. And then I typically will use 6% sodium hypochlorite after that for disinfection, and then I'll go ahead and start mixing my calcium silicate. So in this case, we're using the traditional biodentin in this case. So you're going to see me come in here, take out the cotton pellet, and then we'll go ahead and use an amalgam carrier is what I like to use to apply the biodentin here. So here you can see the biodentin going in, then the cotton pellet will come in after that to compress that over the entire pulpal floor so we get good full coverage there. So we'll bring that in here now. And that one's probably a little too wet for what I like, but you kind of get the idea how we can push that in and compact it. And then I don't like to wait. If you want to wait, you can wait 9 to 12 minutes. That's a long time for a kid. I like to keep moving, so I'll go ahead and put a glass on. This is Revis Self-Cure HV. You can also do a light cure glass RMGI if you want to really move, but this is an EOR. I'll typically do this, and then I'll move to another quadrant, get that done, and come back and do the crowns. So in this case, we obviously went ahead and finished these with some stainless steel crowns. So going up and finishing the preparation for both of these here. I'm going to move forward just a little bit in lieu of time. So we'll go ahead and finish our crown preparation after that. This is the Biodentin XP here. So again, here, another case where we had reversible pulpitis. I've skipped through all the other preparation we did earlier just in lieu of time. Again, using that spoon excavator here to get that pulp tissue out. You can see this does take a little bit more time than using, obviously, a burr to do that. And we'll go ahead and rinse and then come in. I'm going to come in with that 6% sodium hypochlorite here before we get the Biodent and the XP. You can see nice healthy pulp. That's what we want to see. Sodium hypochlorite going in. Now we're going to start mixing our Biodentin. Hopefully take that out if I can get a hold of it here. And then here you're going to see the XP come in here shortly. So it's got a bent tip here. So you can apply that right into the space you want. You don't need to pick it up. It comes titrated in this nice capsule. And go ahead and condense that in, and then come back with your cotton pellet the same way we have before. And then in this case, I used a light cure RMGI just because I was working on this area to go ahead. So you can see this cotton pellet's not as damp. But you can see we get a nice coverage there of the entire pulpal floor. If you want to go ahead and wait, you can. I wasn't patient, so this is a little RMGI Riva light cure here. Going off. And then once it's cured, you can continue prepping your crown right away. So what's new? We'll finish up here with what's new. Go through the questions that they answered. So what's the most reliable method to diagnose the pulp? They didn't really find one. So again, using your clinical subjective findings, your objective findings. And if you're not sure, you've got great options. You can do complete caries removal if you're under sedation. If you're not sure and you aren't doing sedation, maybe put in a glass ionomer, an SDF for a little bit, see how they're doing the next day, or put a temporary crown, Hall crown over it, and call them back and see what they need. Does the presence of preoperative reversible pulpitis pain influence vital pulp therapy? So for primary teeth with preoperative pain, indirect pulp therapy and calcium silicate cement for pulpotomy may be preferred compared to direct pulp capping. So consider that again, looking at those over direct pulp cap, which we kind of highlighted in the first guidelines. Teeth requiring pulp therapy due to deep lesions, which is better. For pulp therapy in primary teeth, the use of indirect pulp therapy or calcium silicate pulpotomy is likely to increase success over other vital pulp therapies, such as direct pulp cap and other pulpotomy medicaments. So either leaving decay or doing a calcium silicate pulpotomy are probably your best options. Again, you're going to be highly successful if you go off that remaining dentin thickness, or if you're not sure, doing one of the other two techniques I just have covered earlier here in this webinar. Again, indirect pulp therapy, does the choice of medicament or liner affect success? Does not impact success. We covered that quite a bit today. For direct pulp capping, does the choice of medicament? It does not affect success based on the limited quality of evidence. I think if you were looking at everything, I think you're probably, if we actually did studies on this that amounted that mass of evidence, I think probably our logic would point to a calcium silicate probably is going to be your best option for a direct pulp cap in the primary tooth. If I had to go out on a limb, I'm speaking on behalf of myself there. For a pulpotomy, does the technique and choice of medicament affect success? Calcium silicates are recommended. Increases success recommended over the use of other medicaments and techniques. Strong, high quality of certainty of evidence at 24 months. Calcium silicates are the gold standard for pulpotomies in primary teeth. You can use the other stuff, but it's not as good. And boy, Dr. Jared Johnson wants to be the best, so I'm going to use the best. Again, here, in the instance of pulp exposure, which treatment is better? A pulpotomy is likely to increase success compared to a pulpectomy for the primary incisor. So a lot of times, if we have that pulp exposure on those anterior ones, I got vital tissue, I'm just doing the pulpotomy over the pulpectomy. I've been doing that for a long time. Which caries removal method is recommended for deep carious lesion regarding vital pulp therapy? For primary teeth with caries requiring vital pulp therapy, selective caries removal is recommended over non-selective. So we're not going and doing 2 steps anymore. We're just going to go ahead, leave the decay, and walk away. Hall crowns are evidence this works really well. I've been doing that for years now. The problem when we get into permanent teeth is now you don't know the history of the tooth, and you get that moving off to the general dentist. They don't get the records, and all of a sudden they're opening up teeth that may not need to be opened up. Nice thing with baby teeth, they fall out for us here. Which caries removal method is recommended for deep caries to prevent pulp exposure? Again, selective caries removal is recommended. Indirect pulp therapy, leaving decay. If you have a millimeter, I'm just prepping. If I'm doing a crown and I have a millimeter, I'm just prepping my crown and I'm done. I know that might sound kind of crazy, but I do Hall crowns and I'm not removing decay. Why would it be any different? How does the non-caries removal Hall technique affect vital pulp success? Had comparable results to selective or incomplete caries removal, and maybe used when indicated. Love it, love it, love it, love it. Which preferred method? Chemo, all these chemicals to remove, or a burr? Just use the approach that you like, and patient cooperation may play a role in this. I mean, you may have some really anxious kids, and it may be a little bit nicer to do it in a way where you're not having to do a bunch of drilling on the tooth and anesthetic. Which is a preferred isolation? There are no studies directly compared to the use of rubber dam. So it's recommended that you use a rubber dam. We may see this change if we get someone to take a look at the isolate and show us, I don't know. I don't know what the answer is going to be for an isolate or Mr. Thirsty compared to a rubber dam. But until that's done, I'm going to be using the rubber dam. Does a method of coronal pulp removal affect the success of a calcium silicate pulpotomy? You can use it, do it anyway. You want to use a spoon, you want to use a curette, you want to use a burr. You're going to be successful either way. It's the bacteria. It's not going to be the removal. I don't take the burr that I just used to remove the decay to remove the pulp, though. If I was going to do that, I'd use a sterile burr. What type of coronal pulp irrigation? I get this question all the time. We don't have any evidence to say sodium hypochlorite is better than chlorhexidine, is better than a sterile cotton pellet. Use what you feel best. If you're in California, you're going to have to use something that disinfects, either the chlorhexidine, the endodontic one is a higher concentration than the mouthwash. So get that straight. You can get that from Ultradent or Vista. Dental also sells a knockoff of the Ultradent one. But I'm using sodium hypochlorite, what I trained with, what's working for me. Use what you're comfortable with. When stopping pulpal bleeding for a pulpotomy, does the use of water, saline, or dry gum pellet improve success? You can use whatever you want. It's going to be the pressure, probably. The sodium hypochlorite may have some of that properties to stop that, but you're going to want to be able to use whatever you like for that. For a pulpotomy, does the type of base over the pulpotomy affect this success? You can use IRM, you can use RMGI. It doesn't seem to alter the success. So use whatever you're comfortable with. I kind of like to go fast, so I might spend a little more with the glass ionomers because I don't want to be sitting there all day working on these kids. But if you want to use IRM and wait a little bit longer, or if you want to wait the 9 to 12 minutes, by all means, go do a hygiene check and come back and wait for that material to set. What is the effect of the MTA pulpotomy if done in 1 versus 2? I would highly, highly recommend whatever you're doing, indirect pulp therapy, or if you're doing a pulpotomy, unless behavior dictates to not continue, you're probably better off in 1 appointment. I think it's Mente's study that shows regardless of material you used, you're way more successful when you restore the same day. When you're either leaving decay or doing pulp therapy, have a pulp exposure, restore the same day. The deal is in the seal. Remember that. If you don't eat, you die. That's why these Hull crowns work so well. So you want to have a great seal. What's the effect of pulpotomy? If the final restoration is placed on the same day or different day, can be placed the same day or different day without affecting the seconds? I would say place it the same day if you can. Please, if you can. What's the effect of the final restoration on the pulpotomy success? Here again, for a calcium silicate, calcium silicate, it says MTA pulpotomy or calcium silicate pulpotomy. You can use the restorative choice that you like. That's a change from the 2020 guidelines. So again, I'm more likely if it's a young kid, you're probably better, a high risk kid, probably better off using a crown. If you got 2 years, you got less time with it. Low risk, you got 1 tooth in the mouth that went bad, you might want to go ahead and restore with composite. So keep that in mind, those factors that go into your restorative procedure and process in your mind of restoring these teeth, translate that over. I mean, if the kid's needs 8 teeth in the back done and they're 3, and the teeth have only been in the mouth for 2 years, you're probably better off doing full coverage on those kids versus 8 teeth on a 9-year-old, now we're talking different longevity. You might be able to get away with something a little bit different, not to go the full coverage. Pulpotomy on anterior versus posterior, equally successful, not likely to differ. Success of vital pulp therapy and trauma. We don't really have any studies in this on primary teeth after trauma. Again, here looking at primary teeth that require pulp therapy, does the location of the lesion or behavior matter? We're not having any evidence showing either way. So I'm going to get into some questions here. I will email you your CE certificate once Adam gets all the attendees over and gets me the registration report back over. This is the code for our AGD credit, CE4DK33. If you did not give Adam your AGD number when you registered, please make sure we get that so I can get you your credit that you deserve. I'm over on Instagram at Dr. Double J's. If you're interested in coming and joining me for a hands-on course, we have a wonderful opportunity, a beautiful training center up in Minnesota. Coming up in June, we're going to do everything: Hall crowns, zirconia crowns, the new resi ceramic crowns, stainless steel crowns, pulpotomies, all this. Septodont's going to be sponsoring the materials there for us. So you get to play with some of these, the Biodent XP. People have really loved that experience up there. We've done that. We've been up there 3 times now, and you get a microscope, or if you want to bring your loupes, just a great experience to be set up to actually learn in a dental environment and not in a hotel. It's just a nice place to be.